So I'm going to be presenting this oral abstract on a 10-year review of peri-procedural complications associated with advanced cardiac implantable electronic devices in East Africa. It was done at a single center at the Aga Khan University Hospital in Nairobi. I have no conflicts to declare. So advanced implantable cardiac electronic devices are largely inaccessible in the majority of sub-Saharan Africa, and the background literature points out to certain factors: high device cost, limited infrastructure, few training opportunities, scarcity of skilled implanters, primary physician inertia, lack of health infrastructure as the main reasons, the main barriers to access. And so the objectives of this study was to try and describe what are the peri-procedural complications defined as adverse events occurring during and after the procedure and before discharge, and to try and identify their predictors. Now, this was embedded in a wider study that just looked at the whole implant practice in this tertiary center for 10 years. But this is the abstract that was presented to Cardiorhythm. And so the trial design was a retrospective cohort. The study site is the Aga Khan University Hospital in Nairobi. It was one of the initiating centers in East Africa for the implantation of advanced cardiac electronic devices, and we began the practice in the year 2012 and have the highest number of implanters in the Republic of Kenya. The time frame was January 2012 to December 2021. Case definition was all consecutive cardiac resynchronization therapy and implantable cardioverter defibrillator implants, revisions and upgrades during the study period. The data source was catheterization lab procedure logs, device clinic records, and electronic charts. The study was internally funded, and ethics was sought from the AKU IREC. Study population was all patients who underwent initial implantation, a generator replacement, or systems upgrade for CRT or ICD devices at the study center during the study period. Exclusion was any record that was incomplete, missing procedural data, or unverifiable data on CIEDs. Baseline characteristics, we had a total of 250 included. The mean age in years was 63 plus and minus 14. Males were 71% of the study population. The mean BMI was 27.8. Hypertension contributed 45%, diabetes 32%, dyslipidemia 18%, ischemic etiology 42%, and functional class 2 and 3 contributed the majority of the presentation. Our study population mimicked the SCAD-HEFT trial and similar trials carried out in Kenya. Intraprocedural, inter and post-procedural adverse events are indicated in the table here, where we had lead re-intervention in 6 patients, technical failure in 5 cases. Technical failure was defined as the failure to implant a lead for any reason, and lead re-intervention was defined as the revision of a malfunctioning lead. Pocket hematomas, 3 cases, a pericardial tamponade in 1 case, cardiac perforation in 1 case, 1 pocket infection, and a case of acute pulmonary edema. Predictors of adverse outcomes in this population included CRT-based devices with an odds ratio of 3.42, an upper limit confidence interval of 1.07, a lower limit of 1.07, upper limit of 10.9, giving a significant p-value of 0.04. Patients who had ischemic heart disease was a borderline positive with an odds ratio of 2.57 and a p-value of 0.05. Now, BMI that was above 18.5 was found to be a protective factor in our study. So obviously the limitations of our study is that we looked at a retrospective cohort in a single tertiary center. So external generalizability is limited. The data source was institutional-based registry data. We screened all the records thoroughly for eligibility and inclusion. This was done by 2 separate investigators. Exclusion of the missing procedure or device data and irretrievable records could be a potential source of bias, but these were few, and so we believe this to have had a minimal impact on our statistics. Obviously, the sample size was small. Like I said, the practice began only 10 years ago and only began to pick the trend towards the end of the decade. We have a low event rate, and the regression model that was used, strength was lessened because of the numbers. So the conclusion is that overall peri-procedural complication rate was low over 10 years. CRT procedures showed a higher complication rate than ICD-based procedures. The key driver was identified as lead placement. So as regional advanced cardiac implantable electronic device services expand, we would recommend targeted training in CRT implantation as essential, with a focus on precision of implantation of leads and key strategy to minimize adverse events through scales optimization. I'd like to thank you for your attention, and I'll acknowledge the contribution of our cath lab coordinator and the medical records in this study. Thank you.
Thank you very much. You have to wait for questions. Don't escape.
Other questions?
I have question. First, I would like to congratulate Aga Khan Hospital, who is one of the sponsors of this meeting, for the records, for the data, and for keeping all these data registered or computerized. And I would like to thank Dr. Jilan, who was one of the members of EXCO, and he was one of the members of the election team. So yes, thank you that you started right, although you said only 10 years, but 10 years is good time for data collection, especially if it is institute-based, no bias, no super selection of cases. So thank you very much, and please join our AFRA. Thank you. I want you with us. Thank you. Okay.
I mean, the low infection rate in your cohort is extremely impressive, considering that there was CRT in ICD patients. Yes, what antibiotic protocols do you use at your hospital?
For the majority of the year, we were using sterile procedure, obviously, but we were using peri-procedural antibiotics, Zinacef, in about 98% of the cohort. And in most of the cases of reimplantation or generator replacement, we were using in-pocket antibiotics in the early part of the decade. But afterwards, we would extend our antibiotic cover 7 to 10 days, and this was consistent, whether it was a hospitalist who implanted, a foreign implanter, or a private practitioner in the institution. They all followed the same protocol.
This is the same practice back in Egypt. We don't follow guidelines. We have our own guidelines, yes, because they will not see my patient with infection, right? So what we do, we give antibiotic parenteral, vancomycin, before the procedure by half an hour or 1 hour, or even if the patient on table, and then we continue with 2 antibiotics after the procedure for 10 days. Correct. So this is the way we keep infection low. Sometimes we irrigate the wound, this according to the operator, Mohammed Saeed or Alfie or me, with garamycin, gentamicin, locally. This is how we minimize the infection rate. And for reimplantation, I mean upgrade or better replacement, we are very cautious with this procedure because we don't want any infection and we don't want any lead extraction.
What about the average length of procedures about the CRT implant?
It was very variable, so it was one of the data points that was collected. So I can't pinpoint, but it was actually very variable across different implanters. But we didn't find that it had any impact on outcomes. So I dropped that analysis.
Do you have a reason, maybe to explain why infection rates in Africa, as opposed to Europe, are slightly higher? Of course, that's the reason why we use prolonged durations of antibiotics, because if efforts are to use the antibiotics and efforts are not to reduce the reasons why, I'm wondering, is it an environmental source of the infection? Any reasons around that?
So I can only speak to institution-based practice unique to the Aga Khan. So we have very protocolized way that we carry out the procedures within the cath lab and these protocols have to be adhered to by all individuals in the cath lab. So I feel that our infection rates do reflect what is found in the Western world. I didn't find that our figures were in excess of what you find elsewhere. But I can't comment to practice outside the Aga Khan, and perhaps I'll allow other implanters with more varied experience to comment.
One of the things I have to commend your institution for is the protocol, because one of the key things that I've seen that raises rate of infection is if you don't have standardized protocol, then you cannot compare. Maybe subjectivity, somebody wants to prep the skin for 1 minute, or somebody wants to do 5 minutes. So I think it's very important to have established protocols. And, and I know one of the biggest data sets was when I was at Duke, they had a standardized Duke protocol. You're going to prep the skin for, with 2 prep solutions. The operator has to scrub or they click the clock. And the antibiotics, the timing before the skin incision. And when you establish standards like that, it helps you to at least know if something goes wrong, you can easily pinpoint where it is. And I must commend what you guys have done, because the infection rate really compared to institutions, normally we always hear about 1% risk of infection. And traveling around different places in Africa, I think I must commend the standardized protocol that you use here.
We found that the source of infection for 2 consecutive cases was the betadine bottle, which was opened before, and they just used it to put in so we prevent this, and we use a sealed one for each patient. That was the reason. We investigated and changed everything, and we found that that was one of the reasons for 2 consecutive infections in my lab. And operator is the key for sterilization, and also sometimes I prevent nurses who are scarfed and have this underarm stuff, not to scrub with me. I said, go put your maillot and come.
In fact, the procedure is scrub nurse scrubs in first, the fellow follows, and then the primary operator. In high-risk cases, the fellow does not scrub in. We
Yes.
have the scrub nurse and the primary operator. So shoe covers, head covers,
Yes,
no long
yes.
sleeves.
I think the operator is number 1 for infection control of any procedure. I taught my team the rules, and as you said, step by step, this is to stop any source of infection. Of course, there is some, but minimum, because infection is a disaster.
I think you guys should probably write out your protocol and share across, maybe even Harvard, so that we can share on the AFRA platform. Yes. So because we have a lot of people starting implant programs, there's some people who have been doing implants. I think maybe if you share that experience, and maybe it can help people in other places here.
All right, I'm going to invite Willie back to this